I'm sorry, I was muted. Oh, goodness. Thank you for your patience with all of our technical difficulties. Thanks for joining. I'm Catherine Martucci, Director of Policy and Programs at the Alliance for Health Policy. And thank you, for those of you who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. And we gratefully acknowledge the Commonwealth Fund for supporting today's webinar. And I will quickly go over some quick housekeeping notes and then introduce our moderator. I want to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive and join our conversation at AllHealthPolicy as well as on Facebook and LinkedIn. And we also want you to be active participants in this discussion as well, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble to submit questions you have for the panelists at any time. We'll be collecting these and addressing them throughout the broadcast. And you can also chat about any technical issues that you may be experiencing. And then finally, please be sure to check out our website, allhealthpolicy.org, where you can find background materials for this event, including speaker bios, a resource list, and an expert list. And then we will also be making a recording of today's webinar and the slide deck there as well, available either today or tomorrow. And now I'm so pleased to introduce our esteemed moderator, Dr. Dora Hughes, Associate Research Professor in the Department of Health Policy and Management at the Milken Institute School of Public Health at the George Washington University. Her work focuses on the intersection of clinical and community health, social determinants of health, health equity, healthcare quality, and workforce. And previously, she was a senior policy advisor at Sidley Austin and served for almost 4 years in the Obama administration as counselor for science and public health. So no person better to be moderating the discussion today, and I will turn it over to you, Dora.
Thank you, Catherine. Good afternoon. I want to start by thanking the Alliance and the Commonwealth Fund for inviting me to moderate this panel on such a critical issue. As we all know, the COVID-19 pandemic has exposed the vulnerabilities and limitations of the U.S. health system and has forced us as a nation to rethink our approach to and investment in public health as our first line defense. Yet, as we have seen multiple times, the pandemic response continues to blur the line between traditional public health and primary care practice, with primary care taking on an expanded role, whether it's testing, communication, and education, and increasingly now, and especially now, with vaccine deployment. According to a new poll by the Commonwealth Fund and the African American Research Collaborative, the majority of unvaccinated respondents want to get vaccinated in their personal doctor's office. This preference for receiving the shot in the doctor's office held across all racial groups and demographic subgroups. Preference for the doctor's office vaccination was particularly high among more hesitant Americans, self-identified Republicans, and rural Americans. This finding is reinforced by personal or primary care doctors being ranked as the most trusted messengers for the overall sample. Also of note, the Commonwealth Fund poll also found that 39% of the unvaccinated say they are not sure how to get vaccinated. This is especially true for younger adults, with 51% of 18 to 29-year-olds unclear about the vaccination process. This uncertainty underscores the need for trusted messengers in the places where Americans are already going for care, which will be critical to both education as well as vaccination. Even as primary care has stepped forward to lead the vaccine effort, we have to acknowledge that the pandemic has placed a major strain on primary care. And we also have to acknowledge that even before the pandemic, primary care was stressed with significant infrastructure, payment, and workforce needs. As the old saying goes, never let a good crisis go to waste. We now have an unprecedented opportunity and significant funding to reimagine primary care to better serve our patients and address inequities, but also to strengthen and contribute to a stronger and more resilient public health system. Today, we are so fortunate to have an amazing panel to discuss not only the challenges, but also the opportunities for frontline providers, how public health and primary care can be integrated and support each other, and importantly, what policy levers are needed and available through the COVID relief and recovery efforts underway. We have an amazing panel, as I said. Their full bios, as Catherine mentioned, are on our website. And for sake of time, I'm just going to share their titles and brief highlights for each. First, we're going to hear from Dr. Rebecca Weintraub, an assistant professor in the Department of Global Health and Social Medicine at Harvard Medical School, and an associate physician in the Division of Health Equity at Brigham and Women's Hospital. Rebecca is also a practicing internist at Brigham and Women's Hospital. Next, we will hear from Dr. Michelle Morse, who serves as the Deputy Commissioner for the Center for Health Equity and Community Wellness, and the inaugural Chief Medical Officer at the New York City Department of Health and Mental Hygiene. Dr. Morse is responsible for leading the agency's work in bridging public health and healthcare to reduce health inequities and serving as a key liaison to clinicians and clinical leaders across New York City. Next, we have Maria Gomez, President and CEO of Mary Center, a Washington, D.C. based nonprofit providing medical, social, and educational services to families. Ms. Gomez founded the organization in 1988 as a clinic to provide prenatal and postpartum care to Latina women living in DC's Ward 1. Prior to establishing Mary Center, Maria was a public health nurse at the DC Department of Health. And finally, we have Ann Griner, who serves as president and CEO of the Primary Care Collaborative, where she is focused on defining and implementing an advocacy, research, and education agenda that will further comprehensive, team-based, and patient-centered primary care. We're going to start today's discussion hearing from Dr. Weintraub, who will provide some overall context on the current gaps in our primary care system. And so with that, I will hand the virtual mic over to you, Rebecca, to kick us off.
So many thank you, Dr. Hughes, for just a tremendous opening statement. I just wanted to add a few thoughts to your assessment, 2 concerning trends and 2 tools for those of you on the call with us today and hoping for your feedback and iteration to make this serve your future use cases. Next slide, please. So as we know, first slide, please. First, we have an unfortunate decline in investment in primary care. So these 3 studies all show an unfortunate negative trend. If you go to the column with the red highlight there, where we're seeing a decrease in investment in primary care throughout these studies, which makes it quite difficult for our workforce, for our planning, and for the resiliency of primary care in the midst of the pandemic. And it's both the finance and the burden that primary care has faced in the pandemic that reminds us not only are they our trusted messengers, our primary care workforce, but the need to think about how we'll re-engage in preventative care as outpatient service delivery has increased. The second trend, next slide, please, is when we think about how we've invested in the COVID-19 relief package. We've seen some promising results. For example, $7.6 billion to expand the public health workforce, $800 million for the National Health Service Corps, tremendous, and these investments are needed. Unfortunately, there were no additional funds were allocated to the Provider Relief Fund, and the loan terms of the Medicare Advanced Payment Program were not relaxed. And a clinician in Raleigh, North Carolina, put this quite succinctly: the amount of money put forth by the CARES Act may be helpful, but it's not going to get us where we need to be. I worry that if practices fail, there will not be anyone around to take care of the members of our communities. A concern in Raleigh, North Carolina, and in many rural areas across the United States. So what I hope to offer today is 2 tools. The first, next slide, please. is a way in which primary care practices can assess the actual calculation of the time and resources they need to administer the COVID-19 vaccines, knowing they're thermostable. They can be in a regular refrigerator for a month at a time, and we'll soon hear that they are shelf stable, so the expiration date will change. And so you can utilize this calculator to put in your own inputs. The modeling will help you actually think through the workforce, the administrative costs, the personnel costs per vaccination, and the equipment supply costs needed per vaccine. And you can see the URL at the bottom. And this collective work was done with colleagues at the Center for Primary Care, Ariadne Labs, and Collective Health. Looking forward to your input. Next slide, please. And to reaffirm what was said previously at the start of the call is not only the importance of primary care for COVID-19 response, testing, and understanding of symptomatology, but what is clear from our African American Research Collaborative, this poll was done in June of this year, is that the preferred vaccine location is my doctor's office. So the column all the way on the left, that dark bar, is 53% of those polled by the African American Research Collaborative preferred to receive the vaccine in the office of their physician or primary care provider in comparison to a retail pharmacy site, a clinic setup, or a large mass vaccination site in their community. So next slide, please, to help you prepare the primary care sites in your communities that do not have access to supply. We built a tool that's updated weekly called the Vaccine Equity Planner. These are public data sets to help you think through where are the vaccine deserts in my community. So on the right-hand side, you see a map of the state of Alabama. All of the shaded areas are areas where individuals need to transport themselves more than a 15-minute drive or a 30-minute pedestrian walk to a vaccination site. And then the red dots you're seeing on the map are current primary care facilities that do not have vaccine today within those deserts. So there's an opportunity to mitigate the vaccine desert if these sites are offered vaccine. And from polling from the Green Center and others, we know many primary care providers are eager to vaccinate, and 74% of them actually are willing to administer the COVID-19 vaccine and are looking for supply from state and local planners. And the URL is on the bottom as well. So here to just start us off with these two concerning trends and two tools to help you plan regarding equitable vaccine allocation and to help primary care providers participate. Over to you.
Thank you. That was very helpful context. Next, I'm going to turn it over to Dr. Morse.
Good morning, good afternoon, everybody. Thanks so much, Dr. Hughes, for the generous introduction, and Dr. Weintraub for those incredible comments. My name is Michelle Morse. I'm an internal medicine and public health doctor. I'm the chief medical officer for the New York City Health Department, and I'm also one of the deputy commissioners there. I'm really honored to speak briefly this afternoon, about some of the work that we're trying to do in New York City around COVID inequities. Next slide, please. I want to start by a quote that always grounds me, especially as a Philadelphian. The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. Every time I read this quote, I think about and pray that 100 years from now, this quote is no longer relevant. Next slide. But unfortunately, what we know in most cities across the country, but particularly true here in New York City, is that we weren't all in it together when it came to COVID. COVID unmasked and made even more visible many of the existing social and structural inequities, as I'm sure you heard a million times. But specifically in New York City, as you see on the left, we are in a moment now where we've had a significant decline and consistent decline in the number of cases. And yet, even with this lower number of people testing positive for COVID-19, as you see on the right-hand side in this heat map, the way that COVID cases are clustering, even at this nadir in the number of cases that we're seeing, is inequitable. And many of the same regions in the city that have been disproportionately impacted by COVID infection, hospitalization, and death, as well as access to vaccination and rates of vaccination, it's unevenly spread across the city. Next slide. So part of the work that I'm hoping to do as the inaugural Chief Medical Officer really relates both directly to what Dr. Weintraub described around strengthening and investing in primary care infrastructure, but it's also really, leading with the health department's vision around health equity. The Center for Health Equity and Community Wellness that I serve as the Deputy Commissioner for is a 500-person team that is really wholly focused on bridging public health and healthcare and addressing health inequities and all of the various intersections that come along with looking at health equity with a really broad lens. So my role and my scope in this particular moment is really about leading with the health department's health equity vision, working with our healthcare delivery partners to do so, and bridging public health and healthcare in ways that get us to a new vision for population health, a population health vision that really allows the health department's incredible expertise in data and epidemiology, as well as understanding social and structural drivers of inequities as a framework for healthcare delivery partners. And COVID, again, has really shown us how important that is. I think if you advance the slide, you'll see that under bridging public health and healthcare, one of the areas that I'll be working on, sorry, could you go back? It didn't show up, unfortunately, but if you could go back to this slide, one of the areas we'll be working on in this realm of bridging public health and healthcare is racism in clinical algorithms. And our public hospital system, Health and Hospitals, has already done tremendous work in this realm. In terms of anti-racist health policy, we'll be looking at the declaration of racism as a public health crisis and an action plan around it. The health department declared racism a public health crisis last summer and is continuing to advance a lot of action items and anti-racist health policy items around how we can actually make the social and structural changes necessary to end racial inequities in COVID and beyond. And then the third is around institutional accountability, and that's accountability for the health department as well as other healthcare delivery institutions across the city around health equity and improving health equity outcomes. Next slide. Some of the work that I've done in this realm in the past was at Brigham and Women's Hospital, actually with Dr. Weintraub, amongst many others, and was specifically looking at instances of institutional racism around heart failure at Brigham and Women's Hospital and how we could actually end that trend and redress the harm that had been done to patients. This inequity that we uncovered and studied and published about a few years ago really helped us to understand how important it is that as members of that institution, we were also responsible for both uncovering examples of inequity and then actually doing the work to remedy those inequities. And that's the same work that we're doing at the New York City Health Department. Next slide. Critical race theory, I think, helps us to understand what frameworks we should be using to both understand, dismantle, and then achieve health equity. And specifically, I think it's important to mention the model that we developed, which is called the healing arc. And it really is about acknowledgement, redress, and closure. It's not reparations per se. It is really acknowledging inequities, racial inequities specifically, redressing them through ensuring that patients harmed by those policies have access to the care they need. And then closure is when the community that's been harmed has agreed or decided that the harm has been remedied. Next slide. But what's clear is that if we don't use race explicit policies to address these inequities, we are going to be in the same situation decades from now, where we see, changes and trends, for example, in median household income over the past 80 years, improving over time, but the gap between Black and white remaining a significant gap despite decades of trends. Next slide. And finally, I think in terms of anti-racist health policy, we have examples that we can learn from history. And I'm sure many of you are well aware of the way that Medicare payment policy was used to desegregate hospitals through Title VI of the Civil Rights Act. We have far more work to do in terms of desegregation as well as institutional accountability for health equity and racial equity. And again, very excited to talk more about what we're trying to do in the New York City Health Department in this realm. Thanks so much.
Thank you, Michelle. Now I'm going to turn the mic over to Ms. Gomez.
Great. Good afternoon, and thank you, Dr. Hughes and colleagues, for your time and the excellent presentations. Mary Center is a federally qualified health center where we practice a social change model that really provides comprehensive health services coupled with social services to address the myriad obstacles that keep our individuals from receiving quality services that support their well-being. In addition, we partner with a 2-generation school program for parents and their children after pre-K, knowing that that if we increase the education, that alters the opportunities for individuals to have health insurance potentially and to potentially get better health access and better health outcomes. So I think that the success of Mary Center has been really the ability to blend and braid funding sources in order to address the social determinants of health. And at the center, in schools, at patients' homes, and through dozens of partnerships with philanthropy, government, the corporations, legal services, and other nonprofits. This was extremely important during COVID, when our communities were the first ones to lose their jobs, become homeless, hungry, many unprotected by the federal and local moratoriums, on rent payments, and also unable to apply for unemployment. After setting up for the testing back in March, our health center, we immediately, the role that we took on was to be the advocate to get money in the hands of our patients, to hold onto their housing, to feed their children and pay for internet, to connect with us and with their children at school. In this vein, we must make internet accessible to the economically fragile in our communities before our next crisis. This is essential. The number of children and adolescents in crisis who had to jump through impermeable obstacles to get connected to mental health providers because of lack of internet is really unconscionable in this country at this time. When we were 100% on telehealth, patients actually had to come to the center to speak to our patients who were to speak to our providers who were actually working at home. So we need to continue to invest on telehealth also to give all persons the confidence and access to this life-saving tool, to continue to invest in the security of that telehealth, right? During the pandemic, we saw that with telehealth, there was an over-increase in compliance with care and some effective efficiencies in care. There needs to be also an investment in home health monitoring. This was essential during the pandemic when we were working from home, to have blood pressure cuffs, to be able to wait, to take blood pressures and blood sugars, to be able to monitor the fetal growth of our pregnant women, and other essential in-home monitoring tools that have become accessible but not covered by some public and private insurance plans. The electronic medical record must be robust to not only allow for healthcare information, but also it was essential during this crisis to get care coordination information, case management, social services, and other non-medical services to be able to really provide the comprehensive care that we needed in the essential care. The health information exchange, CRISP, is really a great start. But I think that a good example is that during the crisis, the primary care center was not able to look at CRISP to see where our patients were in the hospital with COVID. And so I think that there still needs to be a deliberate and quickly interconnection with hospital specialists, primary care, and the public health service. The electronic patient portals are still very difficult. I don't need to tell anyone in this meeting here, but many of our patients also have rudimentary phones and poor knowledge of technology. So we really need to make medical records more accessible to our community. We are at Mary Center welcome the value-based payment reform that is happening and applaud many of the managed care organizations for working with federally qualified health centers on this. We know that, that there's an upfront cost, and yet the savings to the system and to the quality of care for patients is undeniable. That said, the existing reimbursement payments for comprehensive services, such as the ones that are provided at Mary Center and all of the qualified health centers, is not sustainable. We cannot ask our providers to see one more single patient a day without affecting the quality of care, and also, just as important, the well-being of our providers and families, and their families. Primary health providers, providers are seriously considering other alternatives for their livelihood. We are depleting our greatest health resource, its people. Pay for performance and higher rates to address the social determinants of health must be addressed as we come out of this crisis. The workforce, in terms of investing in nursing, nurses were essential to ensure all clinical services were delivered, including COVID testing and vaccinations. Another essential group was our mental health providers. They saved the day for many of our elderly or school-age children and substance use individuals. They were 100% on telehealth, and this was a modality of operation for many of our mental health patients. They loved it, and they continue to really connect with our providers. The social service component was essential to really deal with all the social isolation that was really in many ways killing our patients. And the healthcare coordinators, the care navigators were important with the fragmentation that was happening all over in the healthcare system and continues to. This was essential. We think that primary care, a hybrid, the future of primary care is to really have a hybrid model where patients are getting care both at home and at work, with assistance with technology. The technology is amazing, but it needs to be accessible to everyone. And in the in-person care really is one modality, and maybe it's not always the primary modality that moving forward. But having said that, I leave you with just saying that there are so many disparities already that we want to make sure that when we are looking at these different modalities of care, that we don't once again leave behind our most fragile individuals and economically fragile community, because the technology will get so sophisticated that the disparities will just widen in our community. Thank you.
Thank you for that. It was very helpful. So next I will turn the mic over to Ann Griner for your opening remarks.
Hi, Ann, you're on mute. If you could unmute yourself, please.
And can you click the microphone? Oh boy. And we can't hear you. I don't know if you could click the microphone.
Okay, now I'm in business. I'm not sure why I couldn't unclick my microphone, so apologies. This is an incredibly impressive panel, and I'm both humbled by the challenges that we collectively face, but also very much inspired by what my colleagues are doing to address this set of challenges. So I think that, again, my name is Ann Griner. I'm President and CEO of the Primary Care Collaborative, and I think Dr. Weintraub did a wonderful job setting the context for the challenges that we are facing in both primary care and in public health. And my remarks are going to focus on what might we do on the policy front, and we look forward to your questions and observations and contributions. The first is, thinking about what we currently have in terms of authorized funds. The Public Health Rescue Plan of $312 billion for public health really does represent an incredible one-time opportunity to help rebuild public health, which has been declining in terms of percentage spend for some time. And I think that one of the areas that I think that need to be focused on is modernizing state health departments so that we could better support bi-directional communication and data exchange between primary care and public health. And I think the urgent use case is obviously the vaccines, but you know, as we come out of that and we start to move towards the ability to leverage the 21st Century Cures Act interoperability requirements, we're going to see that patients are going to be wanting to access their records, their vaccines, their preventive care. And so public health needs to take the steps to get data standards in place so that it can provide such data for primary care. And obviously that is a challenge. Primary care does want to vaccinate and has been vaccinating and wants to do more to help meet our vaccine goals, but frankly are challenged in many states to even know who in their patient population is vaccinated. So obviously we've got a lot of work to better integrate public health and primary care information systems. It's going to involve setting data standards that cross borders, and CDC, with the help of ONC, could play a major role in aligning data definitions for collecting public health data and for establishing common standards for data exchange within and across states and with the CDC. In terms of technology and primary care, there is a lot of heterogeneity. In some parts of primary care, there's been a lot of investment in IT infrastructure and analytics. And of course, primary care, unlike public health, had the High Tech Act, you know, over $30 billion investment in electronic, well, that was all of hospitals and all of physicians, both specialists and primary care, but a lot went in to primary care as well to build out information EHRs. But more investment has been coming into primary care through high profile innovators like One Medical and ChenMed and Aledade and Oak Street and the like. And they have built sophisticated IT capability, largely with venture capital and private equity funding. But what we need to see is that these proprietary tools connected to and exchanging with public health. And then on the other side of the spectrum, we have many small and independent practices that really have not been able to go beyond the funding they received for EHRs to further build out their data and analytic capabilities, which really does put them at a disadvantage. And then we have somewhere in the middle our primary care that are attached to health systems. So we need development on the public health side and on the primary care side, you know, to really have this coordinated, connected IT infrastructure that can help us with all kinds of population surveillance, including related to vaccines. There were, I'm a huge fan of the Mary's Center, and I think that Maria Gomez really laid out a case for a more robust primary care. And we are all in favor of that. A comprehensive team that was better able to address social needs and connect to the community with community health workers and really being responsive to patients' social vulnerabilities, integration of behavioral health, integration of oral care, where we also see quite a lot of inequities. I think the challenges, and Maria mentioned this, is that we have not provided enough resources for primary care to build out this team. You know, we've been actually declining in terms of the percentage spend on primary care. But it is not just those dollars. We also need to move to predominantly capitated models, a different way to pay. enable the sort of care delivery transformation that will allow primary care to better connect to the community, to better connect to public health. And, you know, how will we get there? Well, you know, we do believe that we could leverage CMMI in those efforts. Listening to our new administrator there, Liz Fowler, she does describe equity as under the quality rubric, and so that is part of their mandate. And I know that she's going to be very mindful of thinking about how do we leverage potentially new primary care models to address inequities. We also look to understand how existing models that are connecting to the community can better address inequities. You know, we look forward to working with CMMI as they consider what these new models might look like, and also ask them to think about whether or not they should have particular program targeted at the most vulnerable of primary care independent practices. In addition to what CMMI might do, I think we also need to think about CMS and where might there be additional funds for primary care, as well as public health, no doubt, without growing total cost of care. And I think, you know, we think about what might, if we think about how monies might be shifted between Part A and Part B, well, that will require legislation. How might we think about site neutral payment and a windfall that might produce, and how might those funds be directed to primary care? I think we're going to need to be creative because, and I'm going to wrap up now, going the usual course rather, and going back to a health system that basically has contributed to all the inequities that we're seeing, where life expectancy is not growing for the entire population, and even worse for our Black and Brown citizens. We cannot afford to go back to the system we had prior to the pandemic. We need to build a different system to get a different outcome. Thank you so much.
Thank you for that. So if we can all come back on camera and unmute ourselves, and if the organizers unmute us as well as the case may need to be for some of us. I think given the time constraints, normally I like to start with the moderator's prerogative and ask the first round of questions, but we've been monitoring the questions that have come in from the queue. And I think given time, we'll start with the audience questions and make sure we get through as many of those. And as time permits, perhaps we'll have time to come back to some of the questions that I had from your presentation. But I do just want to say the presentations were amazing and just touched on so many different important issues and in such a short period of time. Whether the untapped potential of primary care providers in the vaccine deserts, some of the technology and data challenges, the workforce supply issues, and then also really thinking about what are potentially some of the new models of care. And so I want to start with that last one because I see that there are a number of questions, and I'm just going to throw them open to all of you. I think particularly Maria and Anne and Rebecca, you've all touched on these. But thinking about these newer models of care, primary care, how it can help to also address the public health system. Can you explain further the role of payment and why shifting from fee-for-service to these alternative payment models could produce more comprehensive care, such as what Mary Center and others are doing? So really going the next step, like we're talking about the need for these new innovative models, moving away from fee-for-service. Why does that help? Why should we be trying to adopt more capitated approaches or these more integrated models that have come forth from CMMI through Comprehensive Primary Care Plus or whatnot? Tell us more why that's important and how that's playing out on the ground right now.
Well, I can start, Anne, if that's okay. I just would say that this is a struggle that we've had. I mean, we know from our data and that if we can piggyback to our providers who are doing an extraordinary job and with the few minutes that they have with the client, if we can do a warm hand off to our nurses, to our care coordinators, to our case navigators, both inside of the center but outside of the center, right, in the schools and the place that they work, that takes money. Those people are not volunteering. If it's going to be effective, it takes money. And I think that the way to look at it is money up front, but the outcomes will be better. And as a country, we're building an infrastructure of healthcare providers that start from the bottom. And that person who's a care coordinator or a navigator, doesn't have all the fancy titles, but they're learning. And by being in that system, they then, because we see it every day, they're going to nursing school, they're applying to become social workers, they're becoming part of the healthcare system, even billers. They understand how important billing is. So we're building a workforce of this amazing people that started all the way from the bottom and have seen it from the bottom up, and being sort of sort of coupled with the providers to really allow the providers to really work at the max level of their their medical degree.
Thank you for that. Anne and Rebecca, do you want to add 30 seconds each additional wraparound comments to what Maria shared?
I would say just one quick thing. The Center for Primary Care at Harvard did a study to try to understand what percentage of your revenue needs to be from capitation for primary care to feel comfortable building out a team, and where it was financially viable for them to do so. And it's 2/3. So a large percentage has to be capitated. And when you are less than that, the foot in two canoes analogy comes up a lot, but that's not financially sustainable. So you want to know what your revenue is. If you have a prospective payment, you're more comfortable hiring that next team member and managing against that budget. And it's going to take a lot, I think, to help people practices get there. But I think COVID has shown us that primary care can really change their delivery on a dime, integrate IT and the like.
And Rebecca, I'd love to hear, or Anne, just very briefly, what thoughts you may have on that, but also in addition to the payment and the workforce that Maria mentioned, that capitated allows you to bring in different types of the workforce, and you're talking about the payment, but does the actual structure of the primary care practice, whether it's solo practitioners, staff model systems, whatnot, how does that affect the solvency and the ability to provide equitable access? And also, the second part of the question, this is all from the audience, is what role does technology play? So Rebecca, if you can also provide some additional comments there.
Well, I wanted to build upon that. It's not the vaccine as a product that's limiting the primary care provider to provide the vaccine. And I think that's been a faulty argument. The vaccine is a free federal vaccine. You do not need to show identification. You can go to your primary care practice. It can be in the refrigerator, so it's on the menu at all times. And I think we need to help primary care and the workforce really understand there's not a concern for wastage, for example, that doesn't need to be a concern, or the refrigeration, but we need to make sure they're reimbursed for the conversation. And majority of the time is not only having someone come and sit there, but talk about the effects of the pandemic. The vaccine is a secondary conversation. The economic distress, the remote schooling effects, the effects of their family lifestyles, that time needs to be reimbursed. And we're facing time scarcity, not vaccine scarcity. but we've kind of combined the two, first allowing a primary care provider to have that conversation. It has been phenomenal to have that experience of using a conversation guide with a patient and walk them through. It's a robust conversation to have about the pandemic. The vaccine is one element of re-engaging with your preventative care.
Yeah, thank you for that. Excellent point. We're going to shift the conversation a little bit. Michelle, thank you for focusing so much of your comments on health inequities. One of the questions that we have gotten from the audience is, can you or someone speak to the needs of Native Americans, indigenous populations, and whether you want to speak to that specifically or anyone else on the panel, of course, but also just can you even go the next step and just say very generally, how are you, from your vantage point, with one foot in the public health world, foot in the clinical world, I mean, how are language and cultural barriers being addressed in primary care settings? How may that be contributing, in fact, to hesitancy to seek care, particularly if focusing on immigrant populations? Any thoughts on that, Michelle? I'd like for you to start, but others certainly jump in.
Sure, yeah, phenomenal question. How much time do you have, right? I mean, New York City.
1 minute, 1 or 2 minutes, that's it.
Perfect, I'm glad you answered. But I think what we're seeing in the New York City side of things is, similar to other major cities across the country, significant racial inequities in vaccination rates. And what Dr. Weintraub mentioned is a huge part of it, right? It's really, is the conversation happening about the vaccine at every time someone from the community interacts with the health system, right? Whether that is, stopping by for your primary care visit or some other interaction that you have in the health system, our providers asking, I think, is a huge question. Now, at the same time, I would say in New York City, specifically for indigenous communities, what we have seen is that we have, literally hundreds of indigenous communities that speak various indigenous languages, many of them from Central America. And many of those languages are very difficult to find interpreters for. And so when you're when folks like that, especially folks who are immigrants, when they're interacting with the health system, finding an indigenous language speaker at the point of access to the vaccine, in addition to just general routine primary care, is a profound challenge. And our equity team has been looking at those challenges for language for sure, but also for disability and all the other intersecting marginalized identities, essentially, that sorry, the cat is here, that need to access the vaccine or interested in accessing the vaccine, but the barriers are manyfold, from, as I mentioned, from translation and language access to many others, including disability. And I would also say that one of the greatest successes in our vaccination campaign has actually been our federally qualified health center partnerships, right? The way that we've been partnering with FQHCs across the city for the past 4.5, 5 months now, has really been one of the most productive, efficient, and effective spaces to offer vaccination for people who identify as BIPOC or people of color. And our FQHCs are, over 60% of the people they're vaccinating are people of color. And that's not just because they have an open door policy, right? And they're getting the support and partnership from us at the health department and technical assistance in that realm around becoming vaccinators, but it's also because these are the institutions that are trusted in the community. To your point about vaccine confidence and accessibility, FQHCs are in the neighborhoods and in the communities that we are trying to support and are really trying our best to engage with during this time, this kind of last mile of the vaccine campaign. So everything from language to, again, like geographic accessibility to what kind of primary care institution our New Yorkers are accessing, all have been challenges. But FQHCs, I would say, have been one of the shining lights in our vaccination campaign and have overcome many of those barriers.
Thank you for that. And Rebecca, I want to ask you, if I understand the survey, the African American Research Collaborative Survey, did they have specific findings on Native Americans, or as part of that you might want to comment on very briefly, mindful of time?
Yes, we can add the link to the poll for everyone to consume. And I was not the PI, but yes, you're absolutely right. They did that. I'll just mention one other piece of research. Nitesh Chowdhury, a colleague of ours at Brigham and Women's Hospital, did a very important study prior to the pandemic, showing that most folks are more willing to refill a medicine with a pharmacist who's of the same ethnic group as the patient is. And this is a common occurrence. This isn't related to the pandemic. It's not related to COVID-19 vaccine. It relates to representation and who you're going to have a communication with. And so, once again, in that sense, having that time that we've lost in the midst of the pandemic, people aren't going to refill their meds. They're not having the same interaction at their local pharmacy with their local provider. How do we recoup that time? And how do we then reimburse our primary care providers for that time?
Yeah, excellent point. So again, reinforcing the role of primary care and addressing COVID and other public health challenges. So unfortunately, our time is coming to an end. So I do want to just briefly ask each of our panelists to provide 30 seconds about, in response to the question is, what specific action could the administration or the Congress take to make vaccinations easier in the primary care settings and or strengthening primary care system? So your final, if you had a policy recommendation, what might it be? And Anne, I'm going to turn to you. You already mentioned several excellent recommendations, but I'll start with you. If you had to pick one, what might that be? And ask each of the others to weigh in as well.
I think I would go back to a point that Rebecca made, which is that for this last mile, it seems that there needs to be multiple conversations with folks who lack confidence in the vaccine. And I do think that we need to not have the financial barrier for the primary care clinician be that, you know, none of that gets remuneration. Primary care lost $15 billion, that's with a B. A Harvard a health affairs study showed in 2020. So they're really financially on their back. So I think if we took away that barrier, maybe that would encourage the kinds of conversations we know can go from hesitancy to acceptance of the vaccine.
Thank you. Rebecca, 30 seconds or less.
Just to add to Anne's comments, I think we need to think of vaccination as a family event. You're coming with your elders, you're coming with your children to get your first and second doses. And so we should prepare, which pediatricians have done previously, to think, how can I serve the parent in this moment? Well, I'm optimistic that this fall we're going to hear that we'll have vaccines available for 5 to 11-year-olds. We need to make sure there's vaccines for the parents, the grandparents, the guardians, whoever is bringing that child for the vaccine appointment, to provide for all.
Excellent, thank you. Maria.
Yeah, I couldn't agree with Rebecca. This is absolutely, I think that the disaster in the beginning was to have all these layers. So when the when the daughter brought the grandparent for the shot and the daughter couldn't get the shot, that immediately turned everybody off. So I also think that infrastructure in primary care, we learned so desperately that many of us did not have the space and the means, the negative pressure and all those things that are needed to make sure that we continue to see patients in primary care plus deal with the crisis. So I think that was an important piece. And the other is just continuing to invest in our communities of color, but all communities, for the workforce. We need to make sure that people continue to think of medicine, nursing, social work, and all those fields as something that they want to do. And I call you and I plead to all of you at this meeting, people are not turning to healthcare as a place that they want to do work in. So I just want to make sure that we invest early on, not just in college once they get in there, but early on into the primary school. We think that we believe very strongly in healthcare and education together must come together to really have the best healthcare system.
Thank you. Final word, Michelle? No pressure, but
no,
very briefly.
Absolutely agree fully with the comments from Anne, Rebecca, and Maria already. I would say one narrative piece and one policy piece. On the narrative piece, what I hope we avoid is blaming people who have complications from COVID because they're not vaccinated yet. I think that we can't allow that narrative to take over, particularly considering what we've seen in terms of racial justice and social justice movements over recent years. So I hope that we don't head in that direction in terms of narrative, in terms of blaming people who are not vaccinated. And on the policy side, I think similar to what Maria mentioned around investing in primary care infrastructure, what we saw in New York City was that there are clearly neighborhoods where there are less clinics, hospitals, pharmacies, and healthcare systems. And so it's and it's racialized. And so if we don't find a race explicit way to invest in primary care infrastructure to ensure access, we're going to be in the same place when the next pandemic happens. So I hope that on the policy end, we can actually move in a race explicit direction when it comes to infrastructure investment.
Thank you. Thank you, all of you, for your insights on this issue. I wish we had more time. This obviously was just touching the tip of the iceberg, but excellent presentations, excellent comments. I want to thank all of you again this afternoon. If we want to put the slides back up, just a quick note for those that are still on, please take time to complete the brief survey that you will receive immediately after the broadcast ends, as well as by email later today. We have several other Alliance briefings that are coming up, focusing on tobacco ban, dual eligibles, as well as rare diseases. As always, there will be a recording of this webinar and additional materials available on the Alliance's website. And so again, thank you so much again to our 3 panelists. And if I dare make a final pitch for Rebecca, she mentioned the tool at vaccineplanner.org, and there's also the survey that we mentioned that can be found at covidvaccinepoll.com is 2 resources that I think would be particularly helpful. So with that, we are finished for today, and look forward to our next conversation. Thank you.
Thank you. Thank you.